All right, good afternoon, everyone. My name is Bethany Hamilton. I'm co-director of the National Center for Medical Legal Partnership at the George Washington University. You're joining us here today on May 9th, 2022. It's 2 p.m. Eastern time. We'll be running this webinar today for about 90 minutes. That's to allow for everyone to have ample time for questions and answers. As we know, you all may have a lot of questions about the No Surprises Act. So this webinar is really put together with MLP practitioners from the field and representatives of CMS Socio to help us really understand the No Surprises Act and the role of medical legal partnerships, or MLPs, in helping patients. Patients who are helped navigating very complex systems for care, coverage, billing, and payment issues is something that medical legal partnership practitioners have done for many years. And with this new No Surprises Act, we just want to make sure the entire field is level set and has foundational information to really help patients and providers continue to navigate those systems successfully. Bit of housekeeping. As you all know, you're joining us using the Zoom webinar platform today. And by default, everyone joins on mute. To ensure that we are able to capture, see, and address as many questions and answers as possible, please use the Q&A function as opposed to the chat function. That's where we will be paying most attention to the questions that come in. You're welcome to also share comments using the Q&A, but if you're using the comments, know that we may miss any questions that come in there. We may not be able to get to all of the questions today, but please just submit it and we'll do our best to follow up if there is an answer right now, as things are still being developed in the area of the No Surprises Act. So submit the question. It's very informative to all of the panelists and all of us on today. This webinar will be recorded, of course. It's intended to be very conversational in nature, but we'll make sure that this very basic slide deck, as well as links to resources, links to what CMS Socio representatives will be sharing, will be made available on the Medical Legal Partnership website under resources. If you're logged in, you'll receive, using Zoom and attending live, you'll also receive a follow-up email with information on where to find the recording and slide decks. If you do need any help, if you have any follow-up questions after the webinar, email us at ncmlp@gwu.edu for help. All right, so what are we here to learn today? We do have some really basic learning objectives. However, there might be a learning objective that we didn't capture here, and I think we're going to glean some of that from the Q&A. So let us know what we may have missed, because again, it's informative. But our intended objectives here really to help increase the understanding of how MLPs help patients navigate those complex systems for care and coverage and payment of care. We're going to gain a better understanding of the No Surprises Act and its intentions, excuse me. And then we're going to help the MLP field really find the information that's out there, as well as resources for patients, providers, and advocates working on No Surprises Act out-of-network coverage issues. How are we going to get through all this today? First, I'll just provide, for those of you who might be unfamiliar with medical legal partnership, very, very brief overview of the MLP approach, showing how lawyers are integrated into those healthcare teams to help patients address those health-harming legal needs. Many of you will recognize the slide that I'll use as a visual to support that brief overview. Then you'll hear from MLP practitioners that you know well about how they help patients navigate complex systems for care, coverage, and payment. That's going to be very conversational in nature. And so we encourage you, as they're sharing, if you are an MLP practitioner, if you're not, feel free to use the Q&A, the comment box, share some stories, scenarios, and questions, especially in the Q&A, so that we can get the MLP practitioners to take a look at what is also burning on your mind, and we can try to address today. You'll hear from the CMS Socio team, who so generously donated their time today to support your better understanding of the No Surprises Act. A lot is changing every day. A lot is still under development and being rolled out. But resources were shared in advance to really help us to accelerate the conversation, accelerate your learning, and then provide you with some additional information as it stands today on the No Surprises Act, as well as pointing you to resources. The Q&A will then close out the afternoon, and we'll ensure that you have the opportunity to continue to submit questions to us at the National Center so that we can share that with our friends who are MLP practitioners and CMS Socio representatives as they continue to implement the No Surprises Act. As you have heard, I'm providing the opening and some introductions. Again, I'm Bethany Hamilton of the National Center for Medical Legal Partnership. I've mentioned that we are joined by MLP practitioners as well as representatives from CMS Socio, Jean Ann Skibara of the Division of Consumer Advocacy and Assister Support, Sarah Barbers, Director, Division of Consumer Advocacy and Assister Support, Patrick Edwards, Director of the Division of Consumer Services, Sam Shafson, Compliance and Enforcement Division at CMS Socio, Kay Helm, Market-Wide Regulation Division at CMS Socio, Jenny Frimpong at the Division of Consumer Advocacy and Assister Support at CMS Socio, and then our MLP practitioners, Erin Bouvier, Senior Director for Health and Legal Integration and Payment Innovation at Whitman-Walker Health in Washington, D.C., and Allison Dowling, another MLP practitioner. She's MLP Director of the Cancer Legal Assistance and Wellbeing Project at Georgetown University's Health Justice Alliance. It's a big panel, but I promise these are the experts pulled together to best support you. For those of you unfamiliar with the medical legal partnership approach, let's take a look at the IHELP chart. So this is a version of the IHELP chart that really helps us to better understand how MLP practitioners really utilize legal services to address those health-harming legal needs that make up the body of social determinants of health. So for example, in the category of income and insurance, you may have an individual that was denied food stamps or health insurance, or perhaps they were underinsured, or there was an out-of-network claim, and now they're receiving a bill. That's where an MLP practitioner, having an MLP, will better allow a provider to assist that patient, first of all, screen for the issue, and then assist that patient with connecting to, for example, an eligibility specialist, and then the eligibility specialist can then connect with the attorney, who will be able to provide guidance, legal assistance, counsel, and advice to that individual to address that denied claim. Those sorts of issues are sorts of issues that we know are health harming based on the research and studies. It can result in impacts on biometric data, such as A1C levels or high blood pressure. And those are the sorts of things that can't be addressed by anything in the medicine cabinet, can't be addressed by anything in the medicine bag, and can, however, be addressed by a lawyer who's integrated on a healthcare team as you would with other sorts of specialists. You can see on the screen that there are many other examples of how MLPs assist patients through providing legal services, the advice and counsel to help those individuals really address the social needs, tear down those social barriers that are affecting their health. For today's conversation with the MLP practitioners, you'll learn more about how they are addressing these needs day to day from both a health center perspective and a hospital perspective with cancer patients in particular. Without further ado, I'm going to turn things over to our MLP practitioners to share their initial comments, concerns, and perspectives about how they're helping patients navigate complex systems. Again, as a reminder, please utilize the Q&A function to share your questions with all of the panelists today. After our MLP practitioners have presented, we'll see if we can get to a couple of questions from the audience. And then we'll transition to hearing from the CMS CCIIO representatives here today to talk about the No Surprises Act. I'm first going to turn over to Erin Bouvier from Whitman-Walker.
Thanks so much, Bethany. I really appreciate the opportunity to be here today. So I'm going to talk a little bit about Whitman-Walker and how we support patients with coverage and billing issues. Whitman-Walker is a community health center here in Washington, D.C., serving 20,000 patients annually. And we have an integrated care model that uses workforce specialists. Insurance navigators and lawyers are part of our MLP program. And the insurance navigators are responsible for addressing cost of care issues and barriers. They are also the frontline screeners for other issues that may need a lawyer specialist. So these insurance navigators assist patients with cost of care issues. They screen for eligibility and enrollment. Some of the examples Bethany used just a second ago. They help them enroll in coverage. They provide consumer education throughout the work they do. We think of that as health insurance literacy because we know having an insurance card does not equal access to care. And they are not there just to secure primary insurance coverage, but also to look at what wraparound programs may be available to reduce out-of-pocket costs for people. As a federally qualified health center, we're required to have a sliding fee schedule of discounts for patients under 200% of the federal poverty level. And this team of insurance navigators are the ones who screen for that. And they are the people who are contacted if anywhere in our system someone mentions cost of care. So despite having this team of people focused on cost of care, we across the health center see that there's a real reluctance and fear to talk about cost, basically a money taboo. Our experience is that providers and the care team often don't think it's part of their job to talk about cost, and reception staff often feel inadequately trained or not well versed on cost, or they think that cost and discussions of cost is going to get too clinical in nature, and both they're not positioned where they sit at the front desk to talk about that, or that they aren't the people who should be talking about clinical issues. So everyone says, talk to billing, except that billing is a back-end function, a function that you talk to people after we've generated a bill. So that we see as kind of some initial kind of upfront challenges with this topic. I'm going to talk a little bit about our specialty populations, who are people living with HIV and the LGBT community. These are two populations that often face stigma and discrimination. When people test HIV positive, it's very common for us to hear worry around affordability of cost of care. They've heard medications for HIV are over $1,000 a month, and they think, I'm never going to be able to afford that. Yet when we connect them to an insurance navigator and we talk about what insurance coverage they may have, it's not uncommon for them to find out, oh, their cost sharing for their HIV medication may be $20 a month, not thousands of dollars. Or if they're on Medicaid, they may have no cost sharing. Or we may be able to enroll them in programs like the AIDS Drug Assistance Program that would pay for their premium and their cost sharing on HIV meds. So we see people worrying about the cost of care. Even when we explain those costs, we recognize that often they can either shift to other insurance during open enrollment that might make a service more affordable, or that they're surprised that it's not as expensive as they may have thought. We also see that no matter what somebody's age or education is, they often want help talking about coverage and cost. And so transparency about these things need to be baked into the system. As an FQHC, not only do we have to have a sliding fee scale, but best practices, how do we actually advertise that? And so our patient waiting rooms, we have posters that show, not only that we have the sliding fee schedule of discounts, but what would those costs be for patients based on the category of the income band that they may fall in. We do good faith estimates for uninsured and self-paid patients on services. And then we use social media to post and remind people of our sliding fee schedule of discounts, the fact that we have insurance navigators who can help with enrollment and education around costs and can help fix or help with coverage issues as they arise. So in addition to this education, our team helps when somebody gets a bill, and they help to determine, is the bill correct? Was it a covered service? Was it in-network provider? Was cost sharing applied correctly? And we reach out to providers or insurance companies when we see that it may not have been done correctly. And we appeal lots of denials of coverage. For us, even before the No Surprises Act, that meant appeals on things like gender affirming surgery coverage or balance billing low income Medicare beneficiaries who shouldn't have been balance billed. It also meant tackling unfair, discriminatory applications of cost sharing on things like an HIV formulary. So sometimes we are doing individual representation on these issues, and sometimes we're taking those individual stories And we see trends, and then we are tackling those trends with the payer or an insurance commissioner. So I'm really excited for our continuing discussion today, as the No Surprises Act for us is an opportunity to talk about the issues that consumers face and a legal framework that this law provides to collectively retake the narrative that we all need to talk about money and cost, and that consumer education, transparency, and that requirement of upfront conversation about cost of care is actually incredibly important to access and the ability to help patients. So I look forward to more conversation. Thanks.
Thank you so much, Erin. Again, everyone, just as a reminder, that was Erin Louvier of Whitman-Walker Health in Washington, D.C., sharing MLP perspectives with an FQHC in mind. And now I'm going to turn over to Allison Dowling, also an MLP practitioner in Washington, D.C. She's with Georgetown University's Health Justice Alliance. Allison, all yours.
Excellent. Thank you so much, Bethany. And thank you for involving me in part of this conversation. I'm really excited to be here, and to echo Erin's sentiment, I think this is a conversation that's really important, both from a medical legal provider perspective, but also as a conversation in our everyday life of thinking about the cost of healthcare and how we as leaders in this group can really drive the conversation forward. So I'll start with sharing a little bit about the project that I work with. I am with Georgetown University's Health Justice Alliance, which is a partnership between lawyers, healthcare providers, and future justice leaders here in Washington, D.C. in the pursuit of health equity. And the Cancer Law Project is one of our medical legal partnerships that we have with MedStar Washington Hospital Center's Washington Cancer Institute here in Washington, D.C. And as part of the project, we provide no-cost legal services to Washington Cancer Institute patients. Most of our patient population base are low income, and they are living in poverty, as well as facing a number of different social determinants of health. So as you can imagine, a cancer diagnosis can be really overwhelming for patients. So much like Erin mentioned, I wanted to share a little bit about how our project currently works within the context of healthcare costs and the perspective of helping clients navigate this really complex system, and some of the ways that we have found to be really helpful for our patients and what we've learned through some of the research that we've done with our patients, as well as with the providers that we work with. So the Washington Cancer Institute and the Cancer Law Project really came together back in 2019. So we are a relatively brand new project. And in doing so, we were able to do a needs assessment to figure out what providers really were hoping that a medical legal partnership would provide. And as Bethany shared earlier with her IHELP chart, it kind of hit exactly what the providers were saying were the issues that their patients were facing. And it matched with what we already know. A national survey was done, and it showed that 93% of oncologists believe that their patients face a social determinant of health that's impacting their patient's health outcome. So we know that this is a huge problem, and the number one problem in that category of issues was really financial stability. And when we think about financial stability, a lot of things come up in play, and usually it's the cost of cancer care. So backing up just a little bit, we know that cancer care in the United States is extremely expensive. It's about an $80 billion per year expenditure for patients and insurance companies to get cancer treatment. And the interesting piece of the project that we work on is that we're in a hospital. So we know that cancer care is expensive, not only from the outpatient perspective, but also from inpatient care. So often our clients are experiencing treatment in excess of 1 year. Sometimes it's outpatient treatment, such as chemotherapy. Other times it's inpatient because they're having surgery and need to be hospitalized for sometimes weeks on end afterwards as they recover. And the cost can be really overwhelming. And thinking about it from the perspective of the patient, we learned in our needs assessment that a lot of times patients fear going to the appointment because they don't know how much it's going to cost. and they're uncertain of what their copays would be. They don't understand if it would be covered. They've heard a horror story from somebody else that, oh, the surgery was covered, but the anesthesiologist wasn't covered, and they had this surprise bill. And so a lot of it is patient education and healthcare literacy. Our project works with a tremendous team of patient support workers. So it's a team made up of social workers, a financial navigator, as well as a nutritionist. And so those team members are really able to support me to make sure that the person understands their healthcare literacy, and that they understand, as Erin mentioned, that having an insurance card doesn't mean they have access, that they really need to understand what their insurance looks like and how to use it. But we also learned that patients do have experience in getting bills. And I think one of the biggest takeaways that we have hopefully been able to share with our clients and with the patients is that just because they receive a bill doesn't mean that all of their rights are lost and that they have to pay that bill. We often take the approach that, you know, if the bill seems like a surprise to you, even though we now know we don't have surprises, we shouldn't have surprises, it's really important to run that by either your financial navigator, through your doctor, call your health insurance company, or bring it to the medical legal partner to make sure that that bill looks like it's correct. Anecdotally, I think we see a lot of folks that get very nervous and scared when they think they have a bill and they think there's a cost sharing obligation, sometimes, you know, $10,000, $12,000. And we actually look at that and it's not a bill at all. It's an explanation of benefits. Or we look at the bill and we clearly see that their first insurance was billed and now the second insurance is getting billed, and that's still pending. And so being able to, you know, sort through that with the client is really important. And also it's really important to be able to do that quickly. We know that patients are really, really stressed when they get these bills, sometimes to the point where they cancel all of their future appointments because they're so upset because of it. And by having a team in place, whether it's a medical legal partnership or a financial navigator or trained billing folks that can reassure the client that this is okay, this is supposed to be happening this way, that it's not a bill, that they haven't, you know, incurred all of this debt, can be really critical to make sure that they continue to remain in care and that they meet their regularly scheduled appointments. So I think that's one key component to this process, but also just having these continued conversations with patients and with providers to be able to have this topic come up, you know, whether it be in the exam room or consultations about the financial impact of cancer is really, really important. And I'm really happy that we're all here today to continue that conversation.
Thank you so much for joining us, Allison, and for sharing those remarks as well as an MLP practitioner. I'm going to screen share again here and make sure I provide the audience with a proper, well, I'll just introduce you, the CMS Socio Team. So we're going to transition from hearing from the MLP practitioners now to hearing from the CMS Socio Team, who's going to help us better understand the No Surprises Act. As I mentioned at the top of the call, a lot of things are changing. The No Surprises Act is still being implemented. There are guidances, regulations, things are still coming out. There are also things being tested in the courts, challenged in the courts as well. So you'll first hear from Jean-Ann to provide an NSA overview presentation. Then you'll hear from Patrick, who will talk about the help desk that has been created and is still being, it's still evolving. Things are still being added to it. Calls such as this are certainly helpful so that CMS Socio teams who are working on it can better understand what is continuously needed for the consumers accessing those help desks as well as the advocates. We'll then hear from Sam on NSA enforcement, CMS versus the state versus collaborative enforcement approaches. And then you'll hear from Kay, who will present on the surprise billing scenarios that for those of you who are the lawyers in the audience may especially appreciate. And then you'll hear from Jenny on the good faith estimate and patient provider dispute resolution scenarios. So I'm going to pass it along to Jean-Ann. Jean-Ann, it's all yours. And thank you.
Thank you very much, Bethany, and good afternoon, everyone. I'm going to share my screen. Okay, so I'm going to give a very brief overview of the No Surprises Act, and then my colleagues are going to provide some more focused information about some of the topics that Bethany just described. So I want to note that a more complete version of this presentation is available on the No Surprises Act playlist of the CMS YouTube channel, along with a detailed presentation on the good faith estimate and patient-provider dispute resolution provisions. So the No Surprises Act and implementing regulations ban surprise billing for emergency services. Emergency services, regardless of where they are provided, must be treated on an in-network basis without requirements for prior authorization. The regulations also ban high out-of-network cost sharing for emergency and non-emergency services. Patient cost sharing, such as coinsurance or deductible, cannot be higher than if such services were provided by an in-network doctor, and any coinsurance or deductible must be based on in-network provider rates. The Act and regulations also ban out-of-network charges for ancillary care, like an anesthesiologist or an assistant surgeon at an in-network facility in all circumstances, and ban out-of-network charges for air ambulance services, and ban other out-of-network charges without advance notice. Healthcare providers and facilities must provide patients with a plain language consumer notice explaining that patient consent is required to receive care on an out-of-network basis before that provider can bill at the higher out-of-network rate. So who's protected by the No Surprises Act? These surprise billing protections apply to consumers who get their coverage through their employer, including a federal, state, or local government employer, a multi-employer plan, or through the federal marketplace or a state-based marketplace, or who purchase coverage directly through a health insurance plan. For those who are uninsured or self-pay for care, this rule includes protections to ensure that they know how much their healthcare will cost before they get it and have a way to challenge a bill if it is much larger than expected. The rules don't apply to people with coverage through programs like Medicare, Medicaid, Veterans Affairs Healthcare, or TRICARE, since each of these programs already has other protections against high medical bills. The No Surprises Act protects consumers from surprise medical bills in situations where they can't easily choose a provider who is in their health plan's network. As we noted, this is especially common in an emergency situation when they may get care from out-of-network providers. However, out-of-network providers or emergency facilities may ask consumers to sign a notice and consent form before providing certain services after they are no longer in need of emergency care. These are called post-stabilization services. The consumer should not receive this notice and consent form if they are receiving emergency services other than post-stabilization services. Consumers may also be asked to sign a notice and consent form if they schedule certain non-emergency services with an out-of-network provider at an in-network hospital or ambulatory surgical center. Now we'll talk just a little bit about the good faith estimate and patient-provider dispute resolution requirements. The No Surprises Act also protects uninsured or self-pay individuals from unexpected medical bills. A provider or facility has to give an uninsured or self-pay individual a good faith estimate of expected charges after an item or service is scheduled or upon request. The good faith estimate will include expected charges for the primary item or service the individual is receiving, as well as for other items or services that would reasonably expected to be provided as part of the same scheduled or requested items or services. For example, if a consumer is getting surgery, the estimate might include the cost of the surgery, any labs or tests, and the anesthesia that might be used during the operation. If an item or service is something that isn't scheduled separately from the surgery itself, it will generally be included in the good faith estimate. Other items or services related to the surgery that might be scheduled separately, like pre-surgery appointments or physical therapy in the weeks after the surgery, would not be included in the good faith estimate. So what happens if the bill is more than the good faith estimate? Consumers may use a new dispute resolution process if they get a bill for an item or service that's substantially greater than the expected charges in the good faith estimate. Under this process, consumers can dispute the bill when the bill charges from a particular provider or facility are at least $400 more than the good faith estimate received. Consumers have 120 calendar days from the day they get the initial bill to begin the process. In this process, a third-party dispute resolution organization reviews the good faith estimate, the bill, and the information submitted by the consumer and their provider or facility. This third-party entity will use this information to determine if the consumer must pay the additional charges, or if the consumer can only be charged what was on the good faith estimate, or some other amount lower than the bill. To offset the costs of operating the dispute resolution process while keeping it accessible, HHS will charge consumers an administrative fee of $25 in 2022. However, if the resolution ends in the consumer's favor, this fee will be credited back on their bill by the provider or facility. During the patient-provider dispute resolution process, the provider and patient can continue to negotiate the bill. During this process, providers may not move the bill into collections or threaten to do so, must pause collections if the bill is already in collections, cannot collect late fees on unpaid amounts, and cannot threaten to take any retaliatory action against the patient for initiating the dispute resolution process. If the patient and provider agree on a payment amount, the provider is required to reduce the bill by at least half of the $25 administrative fee. Now we'll talk about a couple of other protections in the No Surprises Act. The external review process allows individuals with group or individual health coverage to appeal a payment for a healthcare item or service that was denied by their health plan due to an item or service not being covered, restrictions on coverage, or the item or service not being considered medically necessary by the health plan. Under the No Surprises Act, coverage decisions that involve whether a health plan is complying with the surprise billing and cost-sharing protections are now eligible for external review. Also starting in 2022, new pricing information will be shown on any physical or electronic plan or insurance identification ID card provided to patients. This information will include applicable deductibles, applicable out-of-pocket maximum limits, and a telephone number and website where consumer assistance will be provided. Additional information may be provided on a health plan's website that can be accessed through a quick response code or a QR code on a physical ID card or through a hyperlink on a digital ID card. The No Surprises Act also protects continuing care patients in circumstances where their treating providers or facilities plan network status changes, allowing a 90-day transitional care period in certain circumstances. And there are new requirements for keeping provider directories up to date and protecting patients who rely on that information. More details about these provisions can be found in the presentation I referenced earlier on the No Surprises Act playlist on the CMS YouTube channel. And now I'm going to turn it over to my colleague, Patrick Edwards, to talk to us about the No Surprises Help Desk.
Yes, thanks, Jean Ann. So good afternoon, everyone. I am here today to talk about a new help desk that is available to users who need assistance navigating the new rights and protections under the No Surprises Act. So as you may know, on January 1st, we launched the No Surprises Help Desk that provides a no wrong door approach to users that intakes, reviews, and triages potential violations of the No Surprises Act and addresses general inquiries about the new rights and protections under the Act. Users have the option of contacting our staffed help desk through our toll-free 1-800 phone number 7 days a week between the hours of 8 a.m. and 8 p.m. Eastern Standard Time, or by utilizing the complaints web forms that are posted on the CMS No Surprises website. Our complaints landing page on the website also provides helpful tips on how to complete our web form, what documentation may be needed, and a summary of what happens during the complaints process. Our help desk offers bilingual help desk representatives in English and Spanish, a language translation line that offers more than 200 languages and uses interpreters who have expertise with medical terminology, and English and Spanish interactive voice response services. Our help desk allows our external partners to receive complaints under their jurisdiction so that users always feel like they have come to the right place. Additionally, even if a complaint or inquiry is not related to the No Surprises Act, we will intake and triage those users to the appropriate state or federal resolution process to really allow an efficient and positive consumer experience. So once a user submits a complaint, They will receive an acknowledgement that their complaint was successfully submitted, a ticket number associated with their complaint, and a summary of next steps. Additionally, at any time throughout the complaints process, users can contact the help desk for additional assistance or a status update regarding their complaint. Next slide, please. All right, so what can our help desk can do? Our help desk will review the complaint for completeness. We will triage the complaint to teams that can investigate or enforce federal laws and policies under our jurisdiction. We will try to identify patterns or problems that may need further review. We'll assist consumers with understanding what documentation they need to submit. And lastly, we'll help answer questions or direct consumers to others that can. Next slide. What our help desk can't do. Our help desk can't require medical providers or help desk facilities to adjust their charges. Our help desk can't make medical judgments or determine if further treatment is necessary. We cannot determine the value of a claim or the amount owed to consumers. We can't assist or intervene with a consumer's payment dispute. We can't call a doctor's office or facility to assist or intervene with a payment dispute. And lastly, our help desk cannot direct a consumer whether or not they should pay a medical bill or pause a debt collection. I also want to note that our help desk may refer consumers to the local state consumer assistance program if the consumer is still experiencing issues with their health insurance, requests assistance with filing an appeal, or would like additional information about the health coverage options not related to the No Surprises Act. And with that, I'm going to pass it off to my colleague Sam for his oversight group presentation.
Great, coming off mute here. Thank you very much, Patrick, and hello. My name is Sam Shafson, and I'm with the CCIIO Oversight Group and help lead the No Surprises Act Provider Compliance and Enforcement Team. And I wanted to quickly talk about the CMS and state and territory provider enforcement landscape for the No Surprises Act. And this applies to all provider requirements outlined in the Consolidated Appropriations Act and the No Surprises Act. Under the statute, CMS will only enforce a provision with respect to the applicable regulated parties if CMS determines that a state is not substantially enforcing that provision. This can occur when a state lacks authority to enforce or specifically requests for CMS to enforce one or more of the given provisions. And at the end of last year and the beginning of this year, CMS published a series of Consolidated Appropriations Act enforcement letters that outline our understanding of the provisions that each state is enforcing either directly or through a collaborative enforcement agreement versus the provisions that CMS will directly enforce. And so to be clear, it is a mix nationwide, and we are building resources to help consumers and providers better understand who has enforcement jurisdiction and under what specific circumstances. I will post a link right after I finish speaking here in the chat that includes all of the letters that went out to the states or that outline the specific state enforcement positions. These letters also communicate whether the federal independent dispute resolution process and the federal patient provider dispute resolution process apply in each state and under what circumstances. And since the provider provisions took effect at the beginning of January, we have started to receive a good number of consumer complaints. As expected, CMS will be handling the follow-up and enforcement for many of these cases, but will also be referring complaints to states and territories as appropriate. To date, of the 350 or so complaints that have come in to the Provider Compliance and Enforcement Team for review, it's probably hovering around 50% of those that have actually been fielded by CMS, and then the other 50% that have been pushed out to and referred to the states who have jurisdiction. Before I turn it over to my colleague Kay, I'll just mention the collaborative enforcement agreement is somewhere in between direct state enforcement and CMS enforcement. States can opt to have a collaborative enforcement agreement so that they can seek, if they do not necessarily have the authority or necessarily the bandwidth to directly enforce at the state level for the No Surprises Act for the different provisions. They can seek voluntary compliance, especially on the provider side I'm focusing on here, but also on the issuer side provisions in the No Surprises Act. And if they cannot get that compliance from the party they are working with, they can then refer it to CMS for direct federal level enforcement. So it's sort of kind of somewhere in between there as kind of a partnership. And there are upwards of 25, 26 or so collaborative enforcement agreements that are being established and will be stood up here in the coming weeks. With that, I will turn it over to Kay, who's going to be walking through some scenarios.
Thanks, Sam. Good afternoon, everyone. My name is Kay Helm, and I'll be walking through just some scenarios to try to help kind of put into context some of the balance billing protections that Jean-Ann went over earlier. And before I get into that, I do want to caveat that so these two scenarios are based on real situations that CMS has received questions about from consumers. And of course, the information they provided wasn't fully complete. And so I'm adding in some details here, some important details to kind of walk through, in this scenario, how the balance billing protections apply or don't apply. But I also make sure to take some time to highlight how and or what information, if different, could change the scenarios and lead it to a different conclusion with regards to the balance billing protections. So jumping in, so with the first scenario, so we received a question about Helen we heard the story about Helen going into an in-network hospital for an X-ray due to a non-urgent sports injury. She was told her private insurance would cover the cost and she received the X-ray. A few weeks later, she received a bill from the hospital charging her the cost-sharing amount for the X-ray at a rate provided by an out-of-network provider at the hospital. She wants to make sure she's not responsible for this much higher than expected bill under the No Surprises Act. So the conclusion up front, so based on the information, the balance billing protections of the No Surprises Act would apply, and Helen is not responsible for paying any more than the in-network rates, the cost sharing amounts for in-network rates for an X-ray. To kind of break down how I got to that conclusion, the No Surprises Act and the interim final rules implementing it states that for non-emergency services performed by non-participating providers at certain participating healthcare facilities, the provider and or facility must not hold the patient liable in excess of in-network cost-sharing obligations unless the notice and consent exception is followed. So with this scenario, the important factors to highlight to determine whether the balance billing protections apply is that first off, Helen has private insurance, so maybe it's through the marketplace. Second, in this case, this is a non-emergency situation, and she went to an in-network hospital. And it's really important to highlight that it's an in-network facility, and that a hospital is an eligible facility for non-emergency services under the No Surprises Act. So specifically under the NSA, for non-emergency services, an eligible healthcare facility specifically refers to either a hospital outpatient department, a critical access hospital, or an ambulatory surgical center. And for the important fact to highlight here is that she received an X-ray, which is considered an ancillary service. So ancillary services, which are services that individuals typically have little to no control over, are always subject to balance billing protections at eligible participating healthcare facility. So that means the notice and consent exception does not ever apply for ancillary services. And so for those reasons, in this situation, the balance billing protections do apply, and Helen, in this scenario, would not have to pay more than the cost sharing amounts for an in-network rate for the X-ray services. Just to highlight a couple kind of alternative situations with the same services in this kind of scenario that could lead to different conclusion. If Helen went to an out-of-network hospital, she wouldn't have the protections even for the exact same services. If Helen had Medicare, Medicaid, TRICARE coverage, she would not have the no surprises protections either, as those programs have separate balance billing protections and regulations in place. And lastly, if Helen went into an in-network hospital for another procedure, say something non-ancillary, and sought out a specific out-of-network provider, that out-of-network provider could have asked Helen to waive her protections via the notice and consent exception. So moving on to one more scenario here. So Bethany took her daughter to an emergency room at an out-of-network hospital on January 14th, 2022, where the daughter received emergency medical services. She presented the facility with her insurance information, but still a few weeks later received a bill from the hospital for $1,600, and it looked like the hospital hadn't billed her insurance. So again, conclusion up front, based on the information, the balance billing protections of the No Surprises Act would apply, and Bethany is not responsible for paying any more than the in-network rates for her daughter's emergency department visit. It's breaking that down. So under the No Surprises Act, it states that non-participating providers and non-participating emergency facilities must not hold patients liable for costs in excess of in-network cost-sharing obligations for covered emergency services. I want to highlight that in this scenario, the out-of-network facility or provider should be billing the insurance first if Bethany presented her insurance information. So that would kind of be the first step for Bethany to try to resolve the situation. But I want to walk through the important factors with this scenario. So first, even though we weren't provided this information, let's assume that Bethany has private insurance. Second, this was in fact an emergency situation that required emergency care. Another factor here is that she did go to an emergency department of a hospital. And again, this is really important that she went to an eligible facility for emergency services under the No Surprises Act. So this, with out-of-network, it's important to highlight with the No Surprises Act, out-of-network providers and emergency facilities are always banned from balance billing. And just really quickly before I turn over to highlight an alternative situation here that would lead to a different conclusion here is if Bethany again didn't have private health insurance, say she had Medicare, Medicaid, TRICARE coverage for that, just for example, again, she would not have these same No Surprises Act protections that Jean-Ann highlighted earlier. So those are just quick two scenarios that I hope help contextualize some of these protections. But so with that, I'll turn it over to Jenny Frimpong.
Thanks, Kay. Hi, everyone. I'm Jenny Frimpong, part of CMS CCIIO's Patient Provider Dispute Resolution Team. And I'm here today to talk through a couple PPPR eligibility scenarios with you. The PPPR process is a really important consumer protection for uninsured and self-pay patients. And in this case, self-pay means someone who may have insurance, but is choosing not to use insurance to pay for this particular item or service. And so for an uninsured or self-pay person to be eligible for the PPPR process, they need to have received a bill that was $400 more than the good faith estimate they received. They need to have a good faith estimate, they need to have a bill, and they need to initiate the PPPR process at least 120 days, from the date of the bill that they have. So a really great resource, I'm going to share my screen really quickly here. A really great resource for you and for consumers is cms.gov, No Surprises. Hopefully everyone's able to see my screen, and if people aren't, someone at some point will stop me, but I am assuming you can. And so if you go to cms.gov, No Surprises, there's a section here called Consumers that's great for you, that's great for the consumers that you aid. And then if a consumer is thinking about participating in PPDR, they can go to medical bill disagreements if you're uninsured and start a payment dispute and come across a lot of really, really helpful information on what they need in order to initiate a good faith. What they need to initiate a PPDR dispute. So here, I'm going to go over a few scenarios that you can find going through the process that I just went through to help you and the consumer better understand if they qualify for the PPDR process. So I'll do 3 scenarios with you today, and you can go through all 5 on your own at a later date or with a consumer. So the first is you get a bill from Dr. Smith. The billed amount is $2,400, and the amount on the good faith estimate that Dr. Smith gave you before your procedure or your item was $2,125. So in this scenario, because the difference between the billed amount and the good faith amount is $275, it doesn't meet the $400 threshold to be able to initiate a PPDR dispute. So in this scenario, the consumer would be unable to take advantage of the PPDR process. In example 3 here, you have your good faith estimate from Dr. Smith for $2,125, and you have your billed amount. The bill you get from Dr. Smith is $2,600. So what's really interesting about this scenario is item 4. Item 4 was something either you or Dr. Smith, likely you and Dr. Smith, did not anticipate you needing. And so it wasn't on the good faith estimate. But after the procedure, after the item of service, Dr. Smith realized that it needed to be billed to you. And so on your bill, this $200 bill exists, but on the good faith estimate, it wasn't there. In order to participate in PPDR, or when you do decide to participate in PPDR, the item that wasn't included on the GFE, but is included on the billed amount, can go towards determining if the difference is $400 or more. So even though item 4 was not on the good faith estimate, because it's on the bill, when we subtract these 2 figures and it's over $400, this consumer can qualify to start the PPDR process if all other eligibility if all other eligibility determinants are on board. And so even though an item may not be on the good faith estimate, if the consumer is billed for it, it all goes into determining if it's part of the $400 or more threshold. So I think that's key to tell consumers when you are interacting with them, that even if something is billed to them that was not on the good faith estimate, it is part of determining if the final cost to them is $400 more than the estimate they were given. And then in the last scenario, example 5, quite a doozy. We've got 2 providers here, Dr. Smith and Dr. Miller. When we look at Dr. Smith's good faith estimate, it was $2,125. And the billed amount comes out to $2,700. And every item on the billed amount was on the good faith estimate. And looking at the difference for Dr. Smith, it's $575 more. The difference is $575. So Dr. Smith's bill can go to the PPDR process. We have to look at Dr. Miller separately because PPDR looks at each provider individually. And if each provider's bill is $400 more than the good faith estimate, that is when we determine if that provider can be taken to the patient provider dispute resolution process. So looking at Dr. Miller had 2 items. The good faith estimate she provided you was $3,025, and the billed amount is $3,925. And so, the total that Dr. Miller provided you was $900, and the billed amount was $1,225. So the difference between the total billed amount and the good faith estimate for Dr. Miller is $325. That doesn't meet the $400 threshold, and so the patient would be unable to take Dr. Miller through the PPDR process. What's key to note for consumers is that even though the total good faith estimate is $900 less than the billed amount. That even though there's a $900 difference between what both Dr. Smith and Dr. Miller told the consumer that they would pay, only Dr. Smith can be taken to PPPR because the items that Dr. Smith billed in relation to the good faith estimate was above the $400 threshold. So there are 5 scenarios. I only went over 3 today. If you're interested and would like to go over more, you can go to cms.gov, no surprises. With that, I will turn it back over to Bethany Hamilton to take us home.
Thank you, Jenny, and thank you to the entire CMS Socio team, the primary panelists who've joined us today, as well as everyone you can see. For audience members, you'll see that it's more than just the primary panelists from CMS Socio that have joined us, but you see an entire army almost of individuals who are implementing the No Surprises Act to really ensure that consumers don't have surprise billing as a barrier to health, to improving their health, and to really helping us increase quality in healthcare, reduce cost, and ensure that population health is improved. I'm going to ask all of our primary panelists, as well as from CMS Socio, as well as our MLP practitioners, to go ahead and turn our cameras on, because we're going to go to the Q&A portion. As mentioned at the top of today's webinar, we are running a 90-minute webinar, so we're going to go for as long as we can here until people have to tap out and continue their day serving clients, serving communities, serving our country, really, and implementation of that. The first question that came in through the Q&A is actually for our MLP practitioners, so I just want to make sure I just prioritize that, and then we'll go into some of the questions that we prepared in advance here. So from the audience, Allison, this question is for you, and I think will be helpful also because I didn't go through this in my overview. It'll help folks better understand the nature of MLPs, how they really work, from screenings to referrals to helping individuals with their client cases, and then working all the way upstream to the policy work. So how does the Georgetown University Health Justice Alliance receive referrals?
Great. Thank you, Bethany. It's an excellent question. And it really depends on a number of different factors. As a new medical legal partnership, with the Washington Cancer Institute, one of my roles is to make sure that providers and patient-forward staff really have the training that they need in order to identify a legal issue and make sure that referral gets to me. So right now, our services are limited to Washington Cancer Institute patients, meaning that all of the folks that I'm helping are in-house, and most of them, I would say almost 90+% of my clients are referrals from providers within Washington Cancer Institute. And then that last 10% are patients who have picked up my business card or received a flyer or have heard about it from maybe another patient and reach out to the Cancer Law Project directly. But it's an excellent point that in order to get those referrals for appropriate legal issues that medical legal partnerships can work on, it really takes the attorney team, the medical legal partnership team to collaborate with the providers, with the front desk staff, because what we learned was so often doctors and nurse practitioners and the nursing team are afraid to, much like Erin mentioned, are afraid to talk about money because they fear that they don't have an answer. And that really extends to any of these problems. If a provider is asking, hey, what's your home life like? And a patient is sitting there saying, it's awful. I have rodents, I have mold, I'm behind on my rent, and they put an eviction notice on my door. And then the doctor is just going to say, oh, I'm really sorry about that. It doesn't feel good. And so having that medical legal partnership where you can actually say, wow, that sounds like there's a bigger problem. Can I please put you in touch with our attorney team who could reach out and see if there's any legal issues to be addressed? We really approach it as we're one more specialist in a whole team of providers. And that's a good way to think of it with the context of cancer care. Our patients are going to a million different doctors, it seems like, and have so many different team members. I'm just one more piece of it. So that's how we handle our referrals. Most of them do come from the provider team and or the patient support team. So that's a team of social workers, financial navigators, and often they've worked the case as far as they can. And then they've reached a point where they're like, I can't advocate anymore. We need a legal appeal. I need someone to file something. And then it gets over to the legal side of things.
Thanks so much, Allison. Erin, can I follow up with you? Because this goes, it's a perfect segue. And thank you, Allison. You set it up, as well as Margaret. Thanks for asking the question. You set it up for us to segue, I think, into drilling down into how an MLP can play a role in, depending on the structure, because Erin represents a differently structured MLP, what role can an MLP play in the No Surprises Act in helping consumers and helping the providers as healthcare organizations really navigate this increasingly complex system, but what's really meant for the benefit of all. So Erin, are you able to share some remarks on how an MLP can continue to play a role in helping everyone navigate now the No Surprises Act?
Sure. I mean, I think we see that no matter what, people want help on coverage and insurance related problems. And so whether that, I think Allison was talking about, whether that's the MLP attorney or a financial counselor, in our case, an insurance navigator, I think we want to make sure that we can connect people to resources. I think the role specifically of an MLP is ensuring that as many people in the system understand, how this works and how to talk to consumers about cost of care, and to be able to have some pretty basic information around reviewing a bill or an explanation of benefits. Allison and I both often find that the bill that comes, like she mentioned in her presentation, isn't a bill at all. It's an explanation of benefits, and it's sort of an initial look at something. We often see also that the bills that they receive are based on, just a problem that happened from even a front desk, like insurance wasn't entered correctly, or, or the secondary insurance wasn't covered, or it went out and it went to their old insurance. And so while it looks like a bill, there may be some initial, things that could be done. And the more people in the system across all of us as providers who can do some triaging of that upfront, and are welcoming of any questions about cost of care. Because, I mentioned that I think there's a real fear about talking about cost, and most people just say, talk to billing. But I think that is not doing, patients a service, and that we need to be more willing to, to answer some basic information, and that more people across the system understand what, the requirements and who we can send people to.
Couldn't agree more. I do want to, if I can, ask the CMS Socio Team if I can go to a question for Patrick next, because we just heard from Erin and Allison about how the MLPs play a role in helping and supporting consumers with billing issues, and how they can play a role in helping to implement the No Surprises Act. But outside of the MLP context, right, which is very limited around the country, right? These are very specialized partnerships and approaches built on agreements, sometimes informal, but still they are structured. It's a structured approach. There's still legal services out there that exist for individual consumers. And so, Patrick, I'm wondering if I can pose this question to you. What might you be able to share about what civil legal services providers in general can do to help consumers? For example, can consumers, when they're calling the help desk or reaching out to submit a complaint, be supported by an advocate from civil legal services? All yours, Patrick.
Yeah, so that's a really good question. So yes, the No Surprises Help Desk does have a process where we will speak to an authorized representative, for example, a civil legal service provider that is assisting with consumers submitting a complaint or an inquiry on behalf of someone else. We will work with that authorized rep to obtain the information needed to submit the complaint. And then once again, after that complaint is submitted, an associated ticket number will be provided along with any next step needed. The help desk may also reach out if additional information or documentation is needed to support that complaint. I do want to note that while we can review the complaint to make sure the insurance company, medical provider, healthcare facility follow the surprise billing rules, it is important to note that our help desk reps are not able to determine the value of a claim, give legal advice, or require providers and facilities to adjust their charges. But all in all, yes, we do have a process in place to speak to authorized representatives. Thanks, Bethany.
Thank you, Patrick. And let me get to another question. Let me put this one back to Erin and Allison for their MLP perspectives, but also note that anyone from the CMS Socio teams, if you do have a sense of how who's reaching out so far, any concerns for specific populations, please feel free to also chime in. So Erin and Allison, for those who are listening in, can you share any perspectives on any particular patient populations or situations that can cause a higher risk for certain groups? Allison, you're working with individuals with particularly high needs, that high cost care needs, which may change depending on what that sort of cancer treatment journey looks like. And one may never know exactly what that looks like, right? It's truly patient by patient. Allison, do you want to take a first stab at that, about any particular populations that we should look out for that may be at higher risk for those sorts of out-of-network or surprise bills that we can better educate or screen for?
Sure. Thanks, Bethany. I think with the cancer patient population, one of the things that we routinely think about is the cost of the actual care. And as a provider, we sometimes forget or should really back up one step further and think about what type of insurance they have. Because with a cancer diagnosis, one of the things that we see frequently is that not only is this cancer diagnosis overwhelming and life-changing from the medical perspective, it often has a trickle-down effect that it's really impacting all parts of their life. So maybe they were fully employed, they had a health insurance through their job, they are part of a 2-income household, and suddenly they've been diagnosed with cancer, and the cancer patient has to step out of that work role. And that means they're navigating a number of different legal issues that hopefully we're helping with, but including changing insurance. So maybe now they're Medicaid eligible, or they have Medicaid, or we're now jumping over to their spouse's insurance versus they've always carried the insurance for themselves. Or all of a sudden they're going to add their spouse's insurance in the next open enrollment because 2 insurances is better than 1. And so navigating that insurance healthcare literacy when you have such a major life transition, being diagnosed with cancer, I think that it creates a situation that's ripe for some of those administrative mistakes, or ripe for just not knowing, does this insurance work as a secondary? How would it work as a secondary? And who do I contact to understand that? And I think that's a role that not only a medical legal partnership can provide, but also, all these different people in the field, whether it's the employer, the doctors, the front desk, the financial counselor, as Erin said, just keeping the conversation going to make sure that people understand what they're signing up for, what they're paying for, and what they actually are going to be receiving. I think sometimes folks think, oh, well, I have 3 insurances, so surely my bill should be 0. And that's not necessarily the case. And just managing people's expectations. So I think that's one critical piece of things that we often forget, that with cancer, not only are they managing the medical diagnosis, often it's a lot of life transitions that are happening simultaneously.
Very true, very true. And Erin, I know Whitman-Walker has a long history as an MLP, being in this exact space. You're as a part of the MLP movement, working with HIV/AIDS patients, in the 80s and 90s, and really helping to address some of those very sorts of issues. We're much further along now in public health, healthcare, and MLP. And so speaking of being much further along, right, we've also identified a workforce that I think CMS Socio, is very familiar with, right? So we have this role of navigators, CHWs, the CACs, the folks who work in that in-between space, really helping to carry out what Allison mentioned, which is the educational piece, the outreach to ensure that the information people need as well as consumers is out there and they also have a contact. Erin, would you be able to share any insights into how, Whitman-Walker might utilize CHWs or navigators, eligibility assistance specialists for helping individuals who might be in higher risk groups better understand who to or how to receive help with the billing issues, or better understand what is a surprise bill, where there's still a lot of misunderstandings around the country with regard to what this act really gets done.
Sure. So I really echo what Allison said, that I think a lot of surprise, or surprise bills or just confusion comes from transitions overall. And so I would say, sort of two things. One, the insurance navigators are here to talk about any concerns of cost of care. But one of the key messages in doing eligibility and enrollment work is that, when there's a change in your family circumstance, your income, someone leaves the household, any of these things can impact your overall eligibility for insurance and your continued eligibility. So you need to check back in, and we need to be, both potentially, obviously in the public health emergency, we have some protections around not reporting changes, but most of the time we're reporting those changes, to Medicare, Medicaid, around what might actually impact somebody's eligibility. That also may mean that, if you have an increase in income, you may now be eligible for a different insurance. So I think we're having those conversations before they take place. I think the second is the place we used to see the most surprise bills is really emergency room care and the coordination and issues that come there. I think some of that is, often emergency care obviously is, something that needed to happen after hours or not when a health center is open. But some of the work that we've done around looking at patients and their emergency room visits and trying to reduce unnecessary emergency room visits are people who are not connected to primary care. And so, the need to look and try to ensure that more and more people have a primary healthcare provider, they understand how to connect. What does, after hours care look like, and how might I avoid unnecessary emergency room care is also part of this reducing the unnecessary, potential surprise bills. I also think often people show up for when it really is an emergency situation and they're confused, right? Like they're focused on what's going on and they may or may not have all of the information about what their insurance is, who is the, what's the number, here's the card. Those things also lead to billing mistakes that may or may not actually be in exactly the context we're talking about, but they still create panic and confusion for the people who receive them. And so I think that the, community health workers, navigators, all are people who are trying to help people connect to care, understand how to better use care, how the system works, and then reviewing some of the things that come in, when somebody brings them a bill so that, we're not, and I think Allison said a few minutes ago, anybody gets worried when they get a bill, no matter how small or big the bill is. And so this is let's not worry until we've actually reviewed it. And that should be kind of a message overall, not that we want to not have people take bills seriously, because we do, but I think the initial panic is not helpful, both for your health, but also just for navigating efficiently what needs to happen next.
That is super helpful to hear. And I think for those who are still becoming familiarized with the medical legal partnership approach, with what Erin really I think perfectly described there is preventative legal advocacy and the benefit of having an MLP, where this idea of having lawyers embedded on the team is not so scary, and it's not like general counsel, but it's really, as you would have, as Allison and Aaron have mentioned, an approach to bring in this specialist to address one of the many social needs, but one that has legal underpinnings, but also can go one step further and help to educate your staff, look at the clinical data sets, do the policy level approaches, do the preventative strategies that help your patient population receive health insurance literacy educations, the CHWs receive the trainings and such. I want to thank Aaron and Allison. Let me pivot to an audience question. Dave, from CMS Socio, Dave Milosky, I'm going to pose this question to you, please. So the question that comes in from the audience: what if a health plan says they don't provide out-of-network benefits at all? Aren't patients still protected from out-of-network surprise bills under situations covered by the No Surprises Act? For example, covered emergency services at an out-of-network hospital, or out-of-network non-emergency ENT services that are covered on an in-network basis at an in-network hospital?
Yes, thank you for raising the question, whoever did raise it. It came in on the chat, but because we get this question a lot, we thought it might make a lot of sense to respond to the question verbally to everyone. And the answer to the question is yes. Under the No Surprises Act, if a plan or issuer covers a service, then that service is subject to the No Surprises Act protections in where the No Surprises Act applies, regardless of whether the plan typically only covers a service on an in-network basis. And I guess the context of this question would probably most frequently come up, for example, in a traditional HMO, where typically they just don't cover out-of-network services at all. But under the No Surprises Act, if the plan or issuer covers a service, typically, even if they only cover it on an in-network basis, then in those situations where the No Surprises Act would apply, it would apply in those cases as well.
Thank you so much, Dave. Appreciate that. And I just want to encourage people to continue to utilize the Q&A function so that we can make sure we capture any additional questions as they come in. Even if we run out of time today, the NCMLP team will be reviewing questions, comments that'll come in, and we'll share those with both the MLP practitioners as well as the CMS Socio team and representatives that have joined us here today. So can put some additional questions here. We've heard a bit about enforcement and where to find resources, but I want to make sure before we lose folks that we just plug for a moment again where people can continue to find resources. Jenny, I know you've done a screen share. I'm actually wondering if you might be able to do screen share, if we can get Jean Ann to do a screen share to point people to those where they can continue to find resources as they come out.
I'm happy to share my screen.
Thanks, Jean Ann.
Of course.
And just as a reminder to everyone, today's webinar is being recorded. We'll have slide decks, and we'll just double check with the CMS Socio team to ensure that we can share the slides that they've shared here today. We did do a transcription service. So for example, the scenarios that Kay walked through, you'll be able to at least see the transcript as he spoke through those scenarios. Jean Ann, your screen share looks good.
Yes, so as Jenny pointed out already, the cms.gov/no surprises website has a lot of information on it, and the adding a /consumers at the end to that, it brings you to the consumer facing pages. I also wanted to mention that we have a YouTube playlist, No Surprises Act playlist under the CMS HHS Gov. I forget what that's called. Channel. It's called channel. In particular, the slides that I walked through partially today, that is the No Surprises Act overview for assisters, advocates, agents, and brokers. That's this one here. And then we also have a deeper dive into understanding good faith estimates in the patient-provider dispute resolution process for assisters and advocates. So those would be the two most likely of interest to the audience today. There was also mention of a chart regarding the applicability of the IDR process, the Federal Independent Dispute Resolution process, federal versus state. And so this is on our CCIIO webpage. where we have just a very simple process that distinguishes between states versus federal versus some combination. And I think
Thank you, Jean Ann. And then before you close out the screen, back on the CMS No Surprises page that Jenny also provided a link to in the chat, that is, thank you, the regs and guidance there. I just want to make sure it's really a one-stop shop where this is the page where complaints can also be submitted. Is that right?
yes, that's correct. Yes.
Okay.
You can go
And
to-
as the regs and guidance page, you just had that pulled up. If folks want to keep an eye out for where those regs and guidance documents will be released, can they also find that by navigating to that exact same page?
Yes, so this would be where the regulations and guidance are. In particular, there's a section on good faith estimates and the Q&A, the frequently asked questions that have already been generated related to that process.
Perfect. Thank you. And for the CMS Socio team, I know that folks on the line, whether they're with MLPs or not, one of the burning questions that people continue to have is just trying to get a sense of what enforcement may look like, and will there be flexibilities? So let me first pose the question about enforcement to the CMS Socio team, and then see if I can get our MLP practitioners to provide any commentary on flexibilities for certain provider types.
Sure. Great.
Thank you, Sam.
Oh, no, absolutely. So from a provider enforcement standpoint, and as we continue to receive complaints, it is CMS's goal and the law's intent to help resolve surprise billing issues for consumers, while at the same time also ensuring that providers are complying with the new requirements. Understanding that there are many providers out there nationwide that may not be super familiar with the No Surprises Act, even at this point, a bunch of months into implementation. So in doing so, our approach will include a series of technical assistance to providers up front as we receive complaints, and then trying to understand how to best resolve. There are potentially a lot of steps in the process, and we anticipate many of these inquiries and complaints may be resolved, and the consumer's issue, if legitimate and founded, will be alleviated before it gets to an investigative stage and or to the point of corrective action or civil monetary considerations. I expect that we will learn more in the coming months as we continue to roll out the No Surprises Act, and we'll adjust this approach to appropriately strike a balance that I just outlined. And as we better understand the complaints resolution landscape. The last thing I'll say is that if we do uncover violations and find they have not reached resolution, we do have the ability to put corrective action plans in place for providers and facilities, and can go as far as moving to lay out and levy civil monetary penalties of up to $10,000 for violations.
Thank you so much, Sam. And Sam, just before you go completely offline or muted, I just want to note that an additional question had come in prior to registration from folks who are interested in this webinar. One of those questions, just anyone from CMS Socio team, just please feel free to let us know if you're unable to answer this question as yet. But there are certain types of providers, such as charity care providers, who are wondering if there's guidance around what enforcement might look like for those providers who don't provide cost estimates, like the charity care providers. So if there is any resource that folks in that bucket can be pointed to, I'll just ask the CMS Socio team to please feel free to plug it. If you're unable to answer it, no worries. We'll continue to look out for guidance. If you'd like to let folks know also where they can reach out, either through their associations, trade associations, or otherwise, please feel free to let them know as well. Before I switch to the MLP practitioners, speaking of flexibilities for certain types of providers, let me just pause to see if the CMS Socio team would like to add anything there. Otherwise, we do have the link plugged by Jenny in the chat for the cms.gov No Surprises website. Okay, Allison and Aaron, speaking of, providers who are in certain categories or are working through this on top of everything else, throughout the pandemic. Any last thoughts on how we can continue to support, as you are in the MLP space, a collaborative space, any parting thoughts on how we can continue to support patients, as well as the providers who are seeking flexibility, such as the FQHCs, who have always been in this sort of space of helping people not have medical bills become a barrier to care. Erin, let me go to you first.
I would just go back to the issue that transparency and increasing all of our ability to talk about cost is really, really important, and that this is a good framework for that. I think the other is, to use your word collaboration, I think as lawyers working in an MLP, typically our first line of defense is not to file some action, or a formal, grievance or dispute or any of that. We are looking at how do we resolve problems at the lowest level possible. And I think that is another takeaway across the space. This really should be for, the healthcare provider community. When somebody raises a concern around a bill, the leaning into how do we help this person resolve this? How do we recognize this is stressful, even if the bill is correct, or if it isn't, like, let's take a look rather than sort of the scripted answers that are often the response that people get when they call a billing office. And so I think I'm so appreciative, of this framework and the protections that are available. But I also think that this infuses something for all of us that we need to look and think differently than we potentially have. And that this is broader than just the protections under the No Surprises Act. This is about, patient empowerment and consumer education.
Absolutely right. I know I've been nodding yes a lot. I couldn't agree with you all more. I am looking at the time. I want to be really respectful of the time that everyone has taken out of their schedules, not just on the panel, but also in the audience. Many of you are providers, advocates, civil legal services folks, people who are also helping to implement the No Surprises Act. And so we also really want to thank you for joining us here today to do exactly as Erin noted, right? Provide patients with another empowerment tool, as well as providers, MLP practitioners who are on the legal side, really help people remove those barriers to care and to improving their health. To the entire team of panelists, CMS Socio staff who helped so graciously to have us pull this together, as well as Erin and Allison who took time out of their schedules away from clients and patients in the community. Thank you for helping us around the country. This webinar has been recorded. We will ensure that in just a couple of days, the rendered recording is made available on the National Center for Medical Legal Partnership website. And we'll see what we can do to make sure all of the slides can come together in a consolidated slide deck. Thank you once again for joining us. Panelists, thank you. With that, we'll call it a close and we'll see you on the next webinar. Take care, everyone.